Good morning. My name's Tom Stelfox, and as Deputy Dean of the Faculty of Medicine and Dentistry, it gives me tremendous pleasure to sort of welcome you to this morning's Department of Medicine Grand Rounds. As I think all of you are aware, Dr. Kassam is finishing her first term as chair of the Department of Medicine, and we really appreciate the service and leadership she's provided during a 5-year period that's seen a lot of challenge and a lot of change. Now, Dr. Kassam has expressed willingness to consider serving a second term as chair of the department. And today, as part of that process, we've got her providing you with a public presentation and a chance for a Q&A. And so the agenda for today is going to be similar, thank you, to probably most of your grand rounds in the sense that there'll be, I'll provide an introduction. Dr. Kassam's going to provide you the presentation. We'll open it up for a discussion. And at the end, I'm going to remind you that you're all going to receive an email with a survey link and ask you to complete that. Okay. From a Q&A, I think it'll be similar to your grand round, which is in the room. You'll raise your hands. Those of you online, please put your questions into the Q&A or chat, and we'll start accepting those anytime. Now, before we start, I'd like to acknowledge that the Department of Medicine, Faculty of Medicine and Dentistry in University of Alberta are located on Treaty 6, 7, and 8 territories, traditional territories of many Indigenous peoples. And for those of us like myself who have the privilege of living on these lands, there comes a responsibility. And that responsibility includes working towards truth and reconciliation, includes trying to sort of foster and preserve a rich heritage, a robust community that's inclusive. And I want to thank all of you for the work you do towards this. Now, I don't know that Dr. Kassam really needs an introduction, but I will provide a very brief one. I received a full one-page summary, which I've condensed down just to a few lines, and that is that Dr. Kassam's an academic general internist. She's trained here at the University of Alberta, as well as at the University of Illinois, Drexel University College of Medicine, and she has served on many local, national, and international leadership roles. She currently serves as Zone Clinical Department Head and Chair of the Department of Medicine. And with that, I sort of ask you to warmly welcome Dr. Kassam.
Hey, good morning, everybody. This really brings back a blast from the past, being back in Classroom D. I just feel like we've come full circle pre-pandemic and now back here. So it's really nice to see you all. I will try to keep today brief because I'd like to have an opportunity really to be able to answer questions. But unfortunately, when I started putting together the presentation, it was like 5 years. My God, so much has happened. And so I may go on a little bit longer than I meant to. I apologize for that, but please know that I am happy to answer questions anytime. I am facing what everybody faces when we go through this, which is oh, there we go. All right, so Tom has done that part already. And I just wanted to add my feelings in terms of the land acknowledgement. You know, when we do this every Friday morning and I rush through the acknowledgement, really, you know, in terms of personalizing it, I think Dr. Stelfox talked about the importance of acknowledging that we're trying to bring equity and understanding and you know, to recognize that there have been sort of these imbalances in care that we've provided to our Indigenous communities. And so this is an organization, the Virtual Care Clinic, the Alberta Indigenous Virtual Care Clinic, that was started during the pandemic. And it's available to anybody that is of Indigenous origin or family members. They're very, you know, they're inclusive. They provide gender appropriate care, Indigenous appropriate care, and you know, sort of looking at different types of medicine and so on. And so I've used their services on a number of occasions when I've discharged patients from emergency. And so I just wanted to bring awareness to it. If you get a chance, if you have to use a service like this, they are wonderful. Okay, so what I'm going to talk about today, I have to have those objectives. Just, you know, sort of outline who we are, because I do think we forget as a department what we represent and who we are, what we've done over the past 5 years and beyond, and where we're going, the vision part, I guess. And I just put that cover up there as a reminder that this past November, when we had the opportunity to celebrate our 100-year anniversary, that, you know, all our accomplishments, really, we got to celebrate the individuals and the accomplishments of the department, and that we really do stand on the shoulders of giants. And so just to recognize that everything that we do, you know, has that mindset to it, that there's many individuals that have come before us that we're very grateful for. So really important, again, to remind us, you know, what our ultimate vision, mission, vision, and values for the department are. These are on our website. They haven't changed. And I think ring true today as they did, you know, 15, 20 years ago when we developed them, to, of course, improve the health and healthcare of current and future generations through excellence and innovation in education, research, and clinical care, to be recognized for innovative works in those pillars, and just towards improving better health and healthcare locally and globally. And then, of course, our values, which speak to leadership, integrity, respect, and caring, collaboration, which I think is very important when you look at where we exist as a Department of Medicine, both within the institution, the wider university, as well as within AHS, importance of partnerships, and transparency and public accountability. You know, I like to, the one thing that I think I take pride in is that piece is very important to me. And especially right now with all the changes that are happening, I think it's really important, the ability to communicate and understand how decisions are being made, where they're coming from, and so on. And then, of course, the importance of continuous improvement. Okay, so this sort of, for me, represents what that mission, vision, and values look like, which is, you know, the three basic pillars that we participate in, which is caring, teaching, and discovering. And we do it for our patients and our populations. These slides really didn't come through very well, did they? But that's okay.
She tested them like she does every Friday.
But it really is important to acknowledge that we do this in the context of the people, that we are united in this mission and vision. And so our people are, of course, our faculty, our students, and our admins. Those of you who came to my presentation 5 years ago know that I'm reusing this slide because this is what that mission, vision, and values represent to me. So that's really what I'm going to talk about today, is starting off with who we are, those individuals that we talked about. So as an academic department, we represent 14 separate academic divisions. We have 17 resident training programs, including 5 primary, who just are in the midst of interviewing for primary CARMs, of course. So that includes our largest specialty program in our institution, the core internal medicine program, dermatology, neurology, physical medicine and rehab, and of course, public health. And then we have our 12 subspecialty programs. So really a large representation of residency training. And then we have 26, maybe even more fellowship programs. There might be some that we're not really sure about, 4 that are recognized by the Royal College as areas of focused competence, so AFCs. And then, of course, we are responsible as a department for all the year 3, year 4 experience that happens in undergraduate education, and then the largest graduate education program in the institution. And then our clinical faculty, or our clinical department. So we have 11, I wrote clinical departments, but it's actually clinical sections. We have 11 clinical sections, but you know, I like to think of the other 3 sections that are outside our clinical area as being part of our clinical family as well, because it certainly has an impact on their academic performance. And we are primarily responsible for 5 urban sites, although we're beginning to expand into other areas. And who do we look after? There we go. So this is the new Edmonton corridor, in case you weren't aware. This is coming forward. And I just point out there that we are responsible for 214 communities within this corridor. And I know many of my section chiefs know this because of the impact this is going to have on the care we provide. This is not even counting the fact that we're responsible for specialty and subspecialty care across the entire northern zone. This is just the communities we're responsible. Just as a comparison, this is Calgary. So I'll just push back 214 communities as opposed to 69 communities. So that alone comes with its own challenges, obviously. And then who are we in terms of faculty, or what do our numbers look like in terms of faculty? So we, within the department, and it actually does fluctuate from, I would say, week to week, month to month, certainly year to year. But as it stands, we have 201 academic faculty members, of which 171 are AMHSP, including TRAS. We have 23 PhD scientists within our department and 3 non-clinical MDs. We have 4 that are special continuing. And altogether, we have 218 AMHSP faculty, but only 204 FTE. And the reason that's important is because we're supposed to be funded for 218 AMHSP, but we can't get to our funding levels for various reasons, which I can go on a diatribe about if anyone ever wants to come and speak to me one-on-one about it. Of the 218 AMHSP, of course, 47 are clinical AMHSP that help us look after our very complex clinical types of clinical patients that we look after. We have 443 CAC faculty members, including 4 FSOs. This is how we are able to administer the teaching program that we do, the massive clinical and teaching program. Currently, we have 50 Red-Eye faculty, but actually we probably have more, but that's all the numbers we could find. Some may not have applied for emeritus status, so we need to do a little bit better with that. And we have 42 adjunct faculty. So those are our numbers in terms of faculty. We do fit that typical inverted triangle that you read about in academic medicine. Although I will pose forward to you that as a department, I still think we're doing better than many other departments, both within this institution and across, I'll just say nationally and internationally. So if you look here, we currently have 117 full professors, I should put my glasses on, 50 associate professors, and still a good number of assistant professors, which, you know, I'm pretty proud of. So we've got 27 assistant professors. So this is just, I thought it would be important to represent this in terms of the gender mix. So we've got, and you'll see the numbers don't add up to the number of academic faculty because these are individuals that have declared their gender. So we currently have a pretty even mixture of assistant professors, but when you get to the associate levels, that's when it starts to diverge. So 27 male and 23 female associate professors, 73 male full professors, and 39 female professors. We've got about a 1.5 to 1 ratio of men to women overall in our academic department, but, you know, definitely a wide divergence there in terms of from assistant to full professors. In terms of our clinical academic faculty, this is, again, something that's really hard to get data on, but overall, we do seem to have a higher mix of men than women in our clinical academic ranks as well, but particularly noteworthy in the clinical professor area. So we've got a bit of work to do. Okay, so what have we done over the past 5 years in terms of recruitment? We've managed to recruit 21 assistant professors, 11 women, 10 men, 6 associate professors, and 6 full professors. So we've done pretty okay. 16 clinical AMHSP, 4 PhD scientists, and I'll just remind you, this is during an era when, in fact, our ability to hire non-AMHSP faculty members within the institution has been very hampered. So there's been some very innovative ways of doing this. And then we've got a number 5 expected in May that Clarence and I are very excited about. And in the meantime, we've also had over 150 CAC hires as well. So it's been busy times. Our Department of Medicine academic office has been extremely busy, as have our division directors in terms of moving forward with these recruitments. So it's been a busy time. And then in terms of promotions, we've had 23 academic assistant professors that have been promoted to associate with tenure, 11 men, 12 women, 22 that have gone from associate to full professors, a nice even split that I'm very proud of, and over 120 clinical faculty promotions, including 18 to clinical professors and 58 from associate clinical to associate clinical professor. So again, lots of work still to be done in terms of, equity and bringing things to a little bit more balanced picture. But, we're getting there slowly but surely. And once again, just need to call out that this could not happen without our academic promotions office, including Gloria, VJ, our AEC, which I heavily rely on, those members. And then, of course, Dr. Morales for the clinical promotions and our clinical academic committee. So it takes a village, and you can see what this village has been able to accomplish. So really proud of this. Next, our learners. So in terms of residents and fellows, we currently have 107 residents in our core IM program. So again, the largest specialty training program in the institution. And there does tend to be a little bit of a heavier male distribution in our program. And then the other primary entry programs account for another 63. Subspecialty, 71 learners, and then we have 41 fellows. So we have nearly 300 postgraduate trainees in our programs. Next November is going to be busy. Program directors know what I'm talking about. And then in terms of undergraduate, of course, as I said, we're responsible for all of year 3 and year 4 training in Med 546 and 556, which is, nearly 165 students per year and continuing to expand. And that doesn't count all the elective students that we have that come through and go, whether it's on subspecialty services or course services or what have you. And then, of course, our graduate program, again, a real source of pride for us. We have almost over 100 master's and PhD students and 40 postdoc fellows. So really large programs. And once again, this happens because of all of you, all of our faculty educators, whether academic track, clinical track, all of our MEPCs and our admin support that allow this to happen almost smoothly. Next is, of course, our admin staff, and these are the folks behind the scenes that make it all happen. So upstairs on the 13th floor, we have our senior management team consisting of 10 individuals. Our academic admins, we have currently a total of 67 with some vacancies. And then our clinical support, we have 4 supervisors. One position's vacant. So currently we actually have 3 that are job sharing and 77 clinical admins. Now, this has been a massive undertaking over the last 5 years. So as you all know, in 2019, going into 2020, we had to separate out our academic and clinical admin support. Gone were the days where we had 2-to-1 admin support providing everything. You just went to one person and you got all your needs looked after. But with the said initiative, we had to restructure. And so I think the Department of Medicine were leaders here. We brought forward this structure which divided up, areas of excellence. And I will admit that some areas are functioning at a higher level than others. We need to bring some other areas up, but we're working towards that. I mean, there isn't a day that goes by, I will say, that I don't get, or at least a week that goes by where I don't get kudos for various individuals and various parts of our teams. Yes, I get complaints as well, but I focus on the kudos. So our admin team has done a really good job. And in case you didn't know, just go to our website, look under admin, and whatever supports you need, they're well outlined there. So these supports are available. We recognize that we still have some work to do there, but I think we're well on our way. So I just wanted to shout out to our admin teams. And then, of course, it does take a village. So this is our leadership team, including Francois Bouman, who's our academic department manager. And we've got a really great relationship with our AHS partners as well. So Fatima, I can never say her last name, so I won't try, who is, of course, the manager for the AMHSP program. And it really does take a village. So, of course, you are all well aware of our associate chairs who do a large amount of heavy lifting in their various portfolios, and without whom I could not do this job, including our new deputy department head. And then, of course, the division directors. So just to acknowledge that some of these divisions are almost larger than some departments and faculties across campus. So even though the university doesn't officially recognize division directors, we have some outstanding individuals that, do that heavy lifting when it comes to recruitments and promotions and faculty well-being, and making sure that all the areas, the 3 pillars, are well represented and covered. And I am absolutely so grateful to these individuals. And our directors. So we've got, our postgraduate, undergraduate, fellowship, graduate program, our clinical faculty director, and of course, our new EDI director. And so I just wanted to, and of course, don't forget our clinical site chiefs, who do a lot of heavy lifting when it comes to the medicine programs across the 5 urban sites. And I just wanted to highlight how busy our office has been over the last little while in terms of leadership development, appointment, and so on. So in this past 5 years, we've had 1 new associate chair, 1 new deputy zone clinical department head, 9 new divisional directors. So we've had 2 that are serving as interim, and a new hire that's going to start in April of 2025, and 1 search and selection ongoing. So altogether 11 if you put 2025 into it. And we've undertaken 4 divisional reviews. We've had a new section chief and a new site chief during this period of time, and we've had a new postgraduate, undergraduate, as well as a new EDI director that's been appointed during this time. And we created 2 new roles during my tenure. One was, of course, the EDI director, but we've had turnover in that position since then. And we created a position for a fellowship director, because we do have 46 fellowship programs, and just needed to what does Michelle Graham say? Herd some cats. And so just bringing everybody together to make sure that we're compliant with policies, and at least within the department, that we're all sharing best practices and so on. So in terms of leadership development and, talking about equity and diversity and so on, we really have tried to be cognizant of changing culture and bringing sort of that ability to recognize yourself, not just succession planning, but for faculty, learners, and the public being able to see themselves within our leaders. So I just want you to be able to contrast what our leadership team looked like in 2019 compared to what it looks like now. A little bit more estrogen in the room. We're still not there yet. We still have a little ways to go in terms of, fully representing the full gamut of diversity, but, we're trying to make strides. And I can honestly say that has been done without any compromise in terms of excellence and leadership. So really proud of this group. Okay, so that's who we are. So what have we done? So of course, just as a reminder, our 3 central pillars: caring, teaching, discovering, and we do it for our patients and our population. So of course, no 5-year renewal talk would be complete without talking about the old pandemic. So of course, you've heard I took over as department chair and zone clinical department head 2 weeks after the pandemic was declared. And that was the department head for the department that was leading the response to the pandemic. And those early days weren't that bad. In 2020, it was more like about planning, panicking, just making sure we had everything in place more than anything else. And then the real work started towards the whether it was the beginning of 21. Well, I still remember, I think you all will recall the whole vaccine fiasco and things like that. And then after that, the work started, or somewhere in there, the work started. And we saw some massive blips, and we confronted them as a department. So of course, we had pulmonary, GIM, ID leading the way, but we had a whole bunch of other areas that just dug their heels in and did the work. And so we had individuals from the Division of Nephrology, Geriatrics, Hematology, and we even had cardiologists stepping up to look after inpatients that had COVID. So, those COVID wards, early days, I didn't want to bring it up too much, but I would be remiss without acknowledging the work that you all did in this area. So just to show you, I don't know if it comes across in the bottom, between 2020 and 21-22, we saw we already had high volumes in terms of our inpatient numbers, but we saw an 18% increase in our admissions. And that's really without any additional new beds or new resources, or, our teams just figured out a way to get it done. So other things, so in addition to obviously being the front line and looking after, planning COVID wards, looking after those patients, providing that leadership at every turn as new challenges came along. Our medicine members also provided key leadership roles in the zone, in the province, and nationally. Robin, that was very appropriate when you walked in as I started talking about that. And this was in multiple areas, of course, in infectious diseases and other areas. We were leaders in post-COVID and recovery programs as well. Whether it was pulmonary medicine clinics, the name of the post-COVID clinic is just leaving me right now. Of course, various specialties participated, including physical medicine and rehab, neurology, cardiology, GIM, hematology, and many others. And we were leaders in virtual care. So we already had the Edmonton Zone Virtual Hospital. We expanded services within the virtual hospital, again, led by medicine. And of course, we had to adopt. So, the largest ambulatory program, we had to adopt to virtual care. And once again, our department members were leaders in this. And then the other challenge we had, of course, was Connect Care. Now, not to say Connect Care came along in and during my term, it started really, we went live at the university site in November 2019, but the planning, of course, started before that. But, the implementation continued through the last 5 years. So we needed quickly developed order sets and ongoing expansion of orders. Our department members participated in that. implementation during waves 2 to 9. So that included all the major sites. And it's not just a challenge for the sites when we implement, of course, it's challenge for the other sites because flow is affected. Where the implementation is taking place, they have to reduce the number of patients they can take. So it's really a challenge for all the sites when implementation happens. And then ongoing enhancement and optimization and leadership. So we've got multiple individuals that have served as CMIOs from our department, medical informatics leads, area trainers, super users, order set development, and just I could go on and on and on. And then, of course, there's been the challenges, I'll say, with the ever-changing Alberta Health Services mandate and so on. So we've lived through many iterations of that. Some of you will remember way back with the Ernst & Young report with those 57 recommendations that early on, I recall in the middle of a pandemic, we were trying to move forward with. Demographic shifts. So I showed the corridor, which is going to come about, but there has been other types of shifts as well with our aging population and volume challenges. So I showed that 18% increase. What's really tough is that we've not really recovered from that, despite the fact that those pandemic waves have subsided. Our numbers have continued to go up, and anybody who does clinical care knows that it's put a lot of pressure on our practitioners. We had to develop alternate coverage models and learner independent teams, and really it's been on the frontline clinicians that we've had to shift how we practice. Certainly not what it used to be. And again, aging population with multiple comorbidities, with a heavier reliance on multidisciplinary teams and the pressures of beds and ALC and so on. But despite that, we've still continued to innovate. And so, I think about the new POCUS teams, for example, that have developed in GIM, in neurology, in pulmonary medicine, in various areas, and other clinical innovations that I could go on and on about that I've had the opportunity to hear about. So that's been in sort of the midst of all of that. And now, of course, we're seeing the early days of the new Recovery Alberta initiative. So more challenges to come. And again, despite all of these challenges, I'm really proud of the work that's happened in terms of ongoing work with the Edmonton Zone Medicine Quality Council, which we started back in 2017, I guess it was. It's gone through a few iterations in terms of name, but central to it is ongoing quality improvement. So we've now developed an ambulatory clinical activities dashboard where you just at a click of a finger, we can access how many patients we're seeing, types of patients we're seeing, and so on. There's ongoing, of course, quality assurance review work that's happening that all the section chiefs and site leads are responsible for and continue to do to improve the services we provide. And then just within the EZMQC, I thought it was important to acknowledge, it's been since 2015, we've got 35 members across the department, a place for individuals that are interested in quality improvement to have a community to practice with. It's aligned with AHS quality departments and now the old SCNs, the new PINs. We've opened it up to undergraduate student electives. Residents participate in quality improvement projects. The program has been responsible for publishing 37 manuscripts and presenting at various fora, including local, national, and international. And of course, we have our yearly QI Day where we highlight the activities. So I just wanted to take this opportunity to thank our partners on the clinical side, which is the Executive Director for Inpatient Medicine, Jennifer Woods, for Ambulatory, Christy, and of course, our QI lead, Dr. Pat Mathura. So on the teaching front, again, our department members show national and even international leadership. We've got individuals that are representing, exam committees, CBD leads at the Royal College level and leaders at specialty societies. And then, of course, we've got within the faculty, postgraduate, undergraduate curriculum assessment and Office of Advocacy and Wellness represented by our department members. And then all the awards that our department members win, right? So some of the ones that are highlighted here, like the 3M, the Macala, CAME certificates, and all of that has happened in the last 5 years. So lots and lots to be proud of. And, you know, I didn't mention it previously, but many of our department members are responsible either as course coordinators or teaching in year 1 and year 2 courses as well. So again, you know, just speaks to how much we contribute. So these are some of the courses that I just to highlight, these are year 3, year 4, which includes core internal medicine year 3, year 4, and geriatrics, of course, which are core requirements. And then we went through undergraduate medical school accreditation. Again, many of our department members were leading and helping through that. And then continuous medical education. We have continued through the pandemic. We were the first ones to restart medical grand rounds. You know, I think it was in April, if I'm not mistaken. We did it virtually, but nonetheless, we still went forward with it. And then eventually came to the hybrid format. And then our annual update, we restarted that in various formats in the early years. And we've again restarted that in-person format. And thank you to Dr. Jennifer Ringrose, who's taken that over. And then, of course, all the subspecialty CME events. You know, every month there's either an endocrinology or a pulmonary or a GI, some sort of update that's happening. So lots and lots of work happening there. So I just wanted to focus 1 minute on postgraduate, which is, you know, a bulk of what we do, and really, really proud of all the program directors and what they've done in terms of taking on all the virtual switch to the platforms. And, you know, I won't go through everything except to highlight the competence by design, which has been a big undertaking for our program directors. And then, of course, they're preparing for the external Royal College review that's going to happen in November of 2025. And then faculty development, lots of work that's happened there. And again, just in the interest of time, because I can't believe it's already 8:38. Won't go through all of that, but lots happening on that front as well. And I just wanted to highlight a couple of initiatives that have moved forward under VJ's leadership, including our Department of Medicine Scholarship in Medical Education and our Medical Education Research Assistant, really all helping us build this medical education community of practice. So lastly is discovery. So this is how we measure up in terms of funding. At the bottom is the years. Of course, we had that massive blip during the pandemic or into the pandemic where there was a lot of COVID work, both, you know, post-COVID and so on that was being funded. And you can see that blip happening here. And, you know, you might think on the face of it that our funding has gone down, but if you actually look at our Tri-Council funding, the last couple of years, it's steady, but we know we still have some work to do there. So that's, you know, a lot of our efforts are continuing to focus on that. And then how do we compare to other departments? So, you know, we continue to lead the way in terms of Tri-Council funding. And then this is total funding. So again, Department of Medicine is here. And again, you know, if you were to look at Tri-Council funding, we're extremely competitive and we've got some work to do in other areas. And then these are clinical trials. So ongoing, you know, lots and lots of income coming in terms of clinical trials. We don't always get to see it as a department, but it's important to recognize that this work is happening. Endowed chairs, you know, ongoing. There's going to be some new ones coming as well as others expire. And again, just to show that we've got lots of individuals, and these have actually helped us do some really key recruitments. And output. So this is, you know, even though our funding has maintained and stabilized, our output continues. So really remarkable how hard people are working and, publishing in really impactful journals. You can see the New England there, European Heart Journal, and I just want to call out that even our clinical faculty members are publishing in high impact journals like Lancet Infectious Diseases and so on. And then graduate programs, again, the largest graduate program, this is recruitment. We've had ongoing interest in our master's and PhD programs. And this is our postdocs, so continual interest there. And our trainees, our graduate trainees win lots and lots of awards. This is just Tri-Council. I mean, if you were to look at all the awards they win across campus, nationally, other awards, we're looking in the millions. So again, really proud of these individuals. And then other research awards that our members have been recipients of, including the Canadian Academy of Health Sciences, Killam, various international, national, and local research awards, and then society awards and lectureships. And I could go on about that. But I do want to just highlight that we did introduce the Translational Research Implementation Fund, which is a departmental initiative. And we've so far given away $160,000 in awards. And this is really meant to help people get data so that they are competitive for larger grants, whether it's Tri-Council or so on. So, it's really effective. And that's obviously thanks to Dr. Mikolakis and his team. And then we've redone our Department of Medicine research website. So if you haven't seen it already, we've tried to make it more user-friendly. And then, of course, our ongoing research and QI day, which we moved to in-person 3 years ago, I think. Just great. It's always a great day. And so just really quickly to go through some initiatives that I'm particularly proud of. Obviously, I've talked about the ongoing leadership and faculty recruitment and promotion. We've got our new EDI mandate that started off by doing a survey and coming up with a 12-step plan that we're now delivering on. We implemented wellness funds for our divisions to really recognize that there needed to be some in-person gathering, whether it was social or whatever, in order to promote recovery. We started our Pulse newsletter. I don't see Betty here, but she's single-handedly responsible for helping us with that. Initially in those early days, we felt we needed to communicate regularly. We had weekly communications, went to bi-weekly, and now we've settled on monthly, and really proud of that, and highlights all the work that people are doing. Of course, we managed to get a new meeting area as of last fall. So that's what that picture is. If you haven't been, it's on the 8th floor. Just ask your divisional administrator for the code to get in, and make sure you use that area. We're planning some great events there. And then, of course, our strategic plan. So that is really the thing that I'm the most proud of. It was very hard when we first started to sit on my hands and not move forward with a strategic plan, but we did eventually do that. So in the end of 2023, we completed our plan. We initiated we highlighted 9 objectives and initiated the implementation phase in 2024 with 6 working groups. And hopefully you were all there on January 10th, or if you weren't, you can access that medical grand rounds where each of the groups presented where things are with regards to the strat plan. So really, when I talk about vision, to me, the next at least 2 to 3 years is going to be about moving forward on that strategic plan. And so this is what it looks like. Again, just in the interest of time, I'm not going to go through too much detail, except to talk about the fact that we've identified leadership development as being important. We've talked about some of the educational innovations that have already been put in place in order to continue to grow our educational community. Research, we've highlighted healthy aging and AI in health, as well as supporting grant applications as important initiatives within the research portfolio. And then in terms of administrative, I already kind of talked about that, but really understanding and getting to a place where we're all, sort of have shared expectations of what admin services should be providing us. 2 that I'm really proud of is one is the external engagement, which is how can we engage the external community? And we haven't, completely defined what external community is. The January 10th grant rounds were really helpful in terms of a direction that we plan to go in and summarizing some of that. So we're really moving forward with that, working with advancement and other areas. And then culture enhancement, the internal community, and Karen Croker is leading that piece, working on sort of some simple ideas of how do we treat each other, initiatives to promote a sense of community, a sense of wellness, a sense of culture. Other things that I see moving forward is clinical services expansion. So, I've already highlighted on the inpatient side, but also on the outpatient side, our physicians are overwhelmed with clinical service delivery. And the reason this becomes important on the academic side is because the clinical part is always going to creep into your time. And so we need to make sure that those clinical services are delivered so our teachers and our researchers can focus on those academic pieces. And so, there's things coming in the pipeline around physician support agreements, looking at potential non-AHS spaces to expand into. And I really do have to thank my AHS partners because they've been really great at helping us with this. We're looking at graduate program expansion. There's some ideas that I've put under there, but one thing we really want to focus on is expanding our clinical scholars program. Yes, we have a clinical scholars program, but unfortunately we don't do a great job advertising it, and we need to do a better job of really increasing recruitment. So more to come on that. And then again, highlighting the amazing work that's happening. So we don't have an awards committee. It's something that I've had sort of on my agenda for a while, but it's sort of gotten sidetracked. And so what we end up doing is these one-offs where we nominate individuals for awards. But my vision is ultimately to have it be more deliberate through an academic, awards committee that with a writer and, to support all of that. And there's more to come. We have identified some resources for that, so we will be moving forward to that. And then last but not least is catching up on the AMHS piece. So most of you know that we are 60 positions behind Calgary in the Department of Medicine in terms of AMHSP positions. So it's actually more than 60 because we can only afford 205 technically, even though we're funded for 218. But even with the 218, we're 60 positions behind. So we need to do some catching up, and we need to think about targeted recruitments, certainly focusing on the academic mission, but also where there is need and where we can continue to grow as a department. There's lots and lots of challenges, not going to lie. Again, talked about expansion, convincing the powers that be that we do need those additional positions. Ongoing budget challenges, which has resulted in us figuring out other ways to come up with resources. I would submit that over the last 5 years, we've done pretty good with our restructuring and with these initiatives that we've put forward and identified resources for our strat plan and so on. But it does challenge us in terms of coming up with resources to fund these initiatives. And then last but not least, of course, this new AHS restructuring and, everything else that goes on with it. And I'll leave it at that because there's lots happening on that front right now. But on a positive note, there's so much to celebrate. And so, these past 5 years, we've continued our annual celebration. We started off doing it virtually, but we've now moved to in-person the last 3 years. And it really is an absolute highlight. I missed it in 2024, but absolutely not going to miss it this year. Celebrating all the accomplishments of our department members, our annual welcome back picnic that we started 3 years ago. Initially, we thought, this is going to be in response to COVID recovery and so on, but it's been so popular. We're going to continue on with it. And then, of course, the highlight this past year, I am absolutely so privileged to have been chair during our 100-year anniversary celebration. And again, the giants whose shoulders I sit on. And thank you to my own personal family who helped me do the work that I love doing. So that's it. I don't know how much time I left.
Okay, great. Thank you very much, Dr. Kassam. So we'll open up for Q&A. I'll ask you to sort of focus your questions on things in Dr. Kassam's presentation and or the future of the department. In the room, please raise your hands. Online, put your questions into the Q&A. And why don't we start? Janice.
Hi, thank you for a wonderful presentation and also your leadership during such challenging times and how visionary you've been. I wonder, what are your priorities going forward, given our new 4 pillars? And in my view, the need to keep hospital care and ambulatory care together for our department.
Thanks, Janice. Janice, thank you for your leadership as our former EDI director, division director, neurology, and now zone clinical department head for neurosciences. So anyone who's heard me talk knows that this has been sort of front and center for me. I mean, Gabe's in the room and knows that to me, specialty ambulatory services are integral to acute care medicine. So the 4 pillars or portfolios Janice, of course, is talking about is AHS or Recovery Alberta. And there is some concern about where ambulatory services fall. You know, you could think about continuing care, think about primary care and so on. But it really doesn't sit there. It sits within acute care because we know that without ambulatory services, that lineup out the emergency door is going to be even longer. And so that's what we have to focus on. Somebody else brought up the point to me is there's programs like transplant medicine. I mean, it just sort of swings back and forth. Sometimes they're in the hospital, sometimes they're out of the hospital. How do you separate those out? And so though that is the message that we've led with, I feel pretty confident that Kirsty, our zone medical director, is also fighting that fight. Peter Jameson, our CMO, is also fighting that fight. So I feel pretty good about it. Of course, the actual truth will lie in what resources AHS is given for us to continue in you know the programs and ambulatory services that we have. And that's why I focus that piece on expanding our ambulatory services, whether it's through the physician support program or looking at non-AHS facilities.
Why don't we go to a question online first? So a question from Dr. Kieran Lee.
Long question.
It's a long question, but effectively a couple of components. First is with the amount of non-evidence-based health activities now occurring in Alberta, example, related to, COVID, for example, what do you see as our roles as a department in responding to address such issues? And then the second one is there's also some very expensive health endeavors that have occurred in recent years, like private telehealth consults, right? And how do we manage that? And I wonder, Dr. Kassam, if you want to use the mic just to make sure that people are online.
For sure. So that's why that piece around external engagement becomes so important that we've identified in our strategic plan. And Adrian Wegg is leading that. And in fact, we've talked about, sort of educating our faculty around how to present in various media format, sort of expanding the reach of the Department of Medicine as an educator and, going to department members and department initiatives as your single point of truth, hopefully. So that has been captured actually, Karen, and I would encourage you to reach out to Adrian to be part of that group because I think that's going to be very important moving forward. It was definitely identified in our strat plan. And then in terms of expensive healthcare initiatives, I don't even know where to start. There's so many, you think about CAR-T, you think about gene therapy, you think about so many initiatives. I will say that those are outside the department's control. Yes, we as specialists need to take control of some of that and advocating, but certainly funding them is not within departmental control, and all we can do is advocate. I mean, the most recent, for example, is the LP clinic that neurology was responsible for starting up just through advocacy. And so that's about the level of control that I can speak to.
Thank you, Dr. Kassam.
Comment on the institutes, I didn't see specifically referenced information or how you wanted to collaborate and integrate the work that we do. Because we have our institutes and there's a lot of cross appointment, but how do you see that?
Integrating?
Yeah, integrating.
So the question was around institutes and how they integrate with the department. So of course, institutes aren't responsible for recruitment. You know, departments are ultimately responsible for recruitment. But I think we've had a lot of partnerships with various institutes across divisions, right? And they're well represented, or at least our department members, I think, are well represented to both leverage what the institutes can provide, and also in turn to provide expertise and resources, whether it's knowledge resources or, you know, when their ability to recruit students and, you know, disseminate work and so on. To the institutes as well. So I see it as integrated across various, you know, sort of, they have their role, the institutes have their role, the departments have our role, and it's very clear to me what those are, but there is a lot of integration, especially when it comes to dissemination, support, and so on. That's how we've run it so far. I didn't put it in the slides because I don't see it changing. I think the institutes are absolutely integral. Certainly when we do academic recruitments, that question always comes up, is how will this recruitment fit into our current institute profile? So when we've had ID recruitments, for example, for Li Ka-shing, NMHI, iSmart now, and so on for neurology and PM&R. So it makes sense for them to have those memberships.
Great. Other questions in the room, online?
Dr. Kassam, good morning. My name is Tom Dust. I happen to be on the review committee as the representative of Provost. So I'm from outside the Faculty of Medicine, obviously. Thank you for your presentation. Speaking from outside the Faculty of Medicine, I found it extremely interesting and informative. So I have a question, and please don't see it as a critique, just it's an item of curiosity on my part. I'm just wondering what the gender balance is in your undergraduate student population, given that you've noted it in all the other cohorts. And just, you know, it's kind of the word on the street out there is that we've got a real shortage of women doctors in Alberta. So, and my daughter's currently applying to various medical schools. I'm very interested in this.
So just to clarify, of course, the department doesn't really participate in undergraduate admissions. We do have members that sit on the admissions committee, but that ultimately is a faculty role. But from what I understand, I don't think things have changed. We're still 55 to 45%. Yeah, 55, even more women. So, you know, I always have this theory that we, you know, girls in general, we tend to do well in school. And we have that mentality for school. So we're very competitive for medical school admissions. Where things seem to fall out is what we're exposed to. So I've actually got a daughter that's going through CARMS right now. And it's been very eye-opening for me, you know, that hidden curriculum piece and what individuals get attracted to. I think we've come a long way in terms of demotivating women towards certain specialties. But there's no question, there is an imbalance. And what I think ends up happening is that there's just different patterns of practice as men and women move along in their careers. So I have this great slide I do when I'm doing these presentations, where I do think that women's careers do move, you know, along a certain trajectory. Just when you compare them to men, it tends to be a little less steep. So men tend to move a little quicker because of the various challenges and so on that, you know, we could go on and on about. Whereas, you know, women just tend to have a little bit of less steep. So, but I think in terms of admissions, we're doing quite well. We do need to look within internal medicine, you know, what it is that is creating that imbalance that you talk about. I hope that answers your question.
Oh, thank you.
Okay, I think what we'll do is we'll call an end to questions there just so we finish on time. I want to thank Dr. Kassam for her presentation and review of the department. I want to thank you in the audience for making time on a relatively cold, although warmer than the last 2 days, Friday morning as we get ready for the weekend. I I want to remind you that you're all going to get emails with a link to a survey. Please take literally the 2 to 5 minutes to complete it. The data will come, it'll be de-identified, aggregated, and shared with the review committee. Okay, if you don't get a survey link, where's Debbie? Debbie, please email Debbie or myself and we'll make sure you get it. And Debbie, the survey's open till when?
Monday at 8
Till Monday, 8 a.m. So so encourage you to do that today so you can have a good weekend. Wishing you all a safe, warm, and relaxing weekend. Okay,